We can go ahead with the next talk.
Thank you so much,
by
sir. Pleasure is all
Dr.
mine.
Supriyo Ghatak. Surgical considerations in locally advanced cancer GB, the fine print, after all the pulsations and gyrations of yesterday.
Good morning, respected chairpersons. Good morning, everyone present in the hall. The topic I'll be talking about is the surgical fine prints about how to go about in locally advanced CAGB. Now, this is greetings from Apollo Kolkata. I work there. We're a team of 3 surgeons. Now, although CAGB has a very dismal prognosis overall, but surgery is the only hope, only chance of cure in a small percentage of patients. I will not go into the details, but I will just say that the locally advanced CAGB that I will be talking about, that is this part T3 and T4, and in terms of lymph nodes, only where the regional lymph nodes are involved, or T3, T4. So these are the 2 things that I will be discussing. As rightly said, that the nodal, apart from the nodal metastasis, pointed out that the distant metastasis is also high even in early stage disease. As we increase, go on increasing, getting the T staging, the lymph node involvement also increases, and we have to also remember that there are sometimes skip metastasis. The hepatorenal lymph nodes are not involved, and the posterior superior pancreaticoduodenal lymph node PSPD sometimes can get skip metastasis as well. Now, the most important factor for long term outcome surgically is R0 margin status and lymph nodal status. In fact, the lymphadenectomy part has been said that it is more of staging purpose rather than therapeutic purpose. So, if you look at the T staging and look at the survival of locally advanced disease is very dismal, especially in the western series. But eastern series, as you can see, it can go up to 40–50%. Do we need to obtain a pre-op diagnosis? Controversial, but presently when a patient presents with a GB mass or suspicious GB wall thickening, we'd like to image the patient. There is controversy about that, but either CT scan, MRI or PET CT, something has to be done thinking that this is a GB mass, and we have to first stage the disease. And if it is an early stage disease and there is a very low likelihood, like the history, that is very important, that where is weight loss, anorexia, all those things are present or not. Depending on the examination finding, everything included, we have to decide whether this is a low likelihood or a high likelihood disease. And depending on that, we have to choose either of 2 strategies. One strategy is, you can see, you can infer from this paper, which are dealing patients who have been re-resected after primary surgery done outside. This is a large series, 80 patients, where they have operated outside and came to the tertiary care center, and there they were staged for incidental CAGB and then operated, and they found the outcome is same. Similar paper are there with not very large number of patients, but the message is almost similar, that the outcome is same whether you operate upfront or you operate after some intervention or some surgery like cholecystectomy has been done. So, in these cases they are recommending that you can, if there is a low likelihood, you can straight away do a cholecystectomy, see the cholecystectomy result, and then go for a re-resection. This is the recommendation in 2019 paper, and they have also said that please the biopsy should be very careful. They should look diligently for tumors in the biopsy specimen, the gallbladder specimen, the cystic duct margin and everything. The specimen should be retrieved in bag, and you have to avoid bile spillage. Now, there is another approach. We know the Lucknow approach, where if there is a low suspicion and could be a gallbladder cancer, we can do a wedge resection of the liver with gallbladder and do a frozen section, and it can either we can just avoid the lymphadenectomy if it comes negative. Similarly, there are scores. This is from Gangaram Hospital, that to diagnose xantho, differentiate xantho from the carcinoma gallbladder. But again, ultimately everything depends on the histological diagnosis, whatever imaging or scoring, whatever you do, but ultimately it is the histological confirmation that will guide your surgical decision. Now, if there is a high likelihood of cancer and you are otherwise it is either early stage or advanced stage, locally advanced disease, if you are operating during intra-op, you have to take multiple intra-op core needle biopsy and do frozen section, and if it comes to be negative, then only you are justified to do a cholecystectomy. Otherwise, depending on the biopsy findings, you have to go for the radical surgery. But radical surgery without histological confirmation, they are saying that it should be avoided. This is a 2015 expert consensus statement. Now, in some settings, obviously, if you are considering neoadjuvant therapy, I am saying considering, although it is like everyone is moving towards the neoadjuvant therapy, but not everyone following it. So, if you are considering neoadjuvant therapy, then definitely preoperative biopsy is a must. Now, resection after neoadjuvant chemotherapy, I will not go into details. Sir will be saying, as I see that the next talk is on that. But only thing is, do we have enough evidence? I think sir will discuss. And only thing I want to say is, there are series from Eastern world where they have shown very good 5-year survival with upfront surgery in locally advanced disease, which is similar to patients' outcome who have been given neoadjuvant chemotherapy followed by surgery. So, you can see the survival, 5-year survival is about 52% and 44%. These are without any neoadjuvant chemotherapy, and these are very large series, 274 patients and 338 patients, something like that. And also now radiotherapy is being added. They are also compared also chemotherapy versus chemoradiotherapy. And coming to the surgical part, it is now more or less clear that only wedge resection is enough with an R0 margin. Formal segment 4B and 5 resection is not necessary unless it is required for an R0 margin. Similarly, routine major hepatectomy or pancreaticoduodenectomy is not recommended unless it is required for vascular pedicle involvement or it is required for your R0 margin. Extent of lymph node dissections. As I said before, this is more of staging purpose rather than therapeutic. There is no definite evidence that it helps in patient survival. Some papers are there, but still. And what we have to do is, we have to remember is that we have to clear the entire hepatoduodenal ligament and hepatic artery and posterior, that PSPD lymph node. These have to be removed, and a minimum of 6 lymph nodes are recommended to be removed before saying that this is N0. Bile duct resection is only recommended when the cystic duct margin is positive. It is not routinely included, should not be included, and it should not be, most of the times it is not required for lymph nodal clearance. Very rarely you will need to take out the bile duct for lymph nodal clearance. Similarly, port site excision is considered to be a metastatic disease, systemic disease, and there is no role of port site excisions. Although this is not part of the, I think, locally advanced gallbladder cancer discussion. Adjacent organ resection is again, if required, you have to do these things, stomach, duodenum, colon, but they are associated with very high morbidity and mortality. And there are studies from Tata which have said that after giving neoadjuvant chemotherapy and chemoradiotherapy, they have found that patients who were imaged as adjacent organ involvement during surgery, they found that all of them were managed with only radical cholecystectomy, extended cholecystectomy and lymphadenectomy. They did not need any organ resection. That is very important. Now, the surgical principles are like, ideally we should get a staging laparoscopy. It can upstage the disease, avoid a laparotomy. Aortogoval lymph node first to be sampled and sent for frozen. If it is positive, then abandon the surgery. Then the standard thing like inflow control and do the liver resection and then do the lymphadenectomy. Also important to send the cystic duct margin for frozen section. and a minimum of 6 lymph nodes have to be resected. Now this is the PSPD lymph node that I was talking about. It is behind the head of the pancreas. Now T4 disease, should we try to, they are part of the locally advanced disease, but should we resect them? Because there are some recent papers, as you can see, if the disease is T4 or CA99 is very high, like more than 200 or more than 250 disease, it is considered, not considered, the outcome is same whether you operate or you don't operate. The outcome remains same. So people are questioning whether to go for surgery with a curative intent in case of T4 disease. This is another recent paper. This was published in 2020, where they have found out some factors like liver invasion more than 5 millimeter left margin or the entire area of the hepatorenal ligament invasion, and more than or equal to 4 lymph nodes in the regional lymph nodal stations. If 2 factors are positive, the 5-year survival is only 5.8%, and if 3 factors are positive, then it is only 0%. This is patients who have been operated for locally advanced CAGB. So to sum up my slides, the imaging has to be either CT, MRI or PET CT. We prefer to do a PET CT. We will consider neoadjuvant chemotherapy more so for T4 disease, and staging laparoscopy must be done. Aortic lymph node first to be sampled, and the standard procedure is only wedge resection of the liver with gallbladder and lymphadenectomy of the HDL ligament, including the PSPD lymph node. Try for 6 lymph nodes, cystic duct margin to be sent for frozen section, and for T4 disease or high CA99, we may consider only systemic therapy instead of surgical therapy, and try to avoid multi-organ resections. Thank you.
Thank you, Dr. Ghatak, for a nice presentation. The talk is open for questions from the floor, if there are any. As the questions keep coming in, Supriyo, as a surgeon, what would you prefer in a locally advanced gallbladder, neoadjuvant chemotherapy or neoadjuvant chemoradiation? Because I believe neoadjuvant chemoradiation in rectum and gallbladder are two different vast diseases, two different vast areas.
The evidence is very thin for either of them for, I think, at this moment, but we rely on our oncologist friend or the radiotherapist friend what they decide, because there is no fixed protocol as such. It is individual preference, I may say. In our institution there is no formal study or anything going on, so I cannot actually say which one is better for that. I think sir will be saying on that. So
I believe, Dr. Goel, that's a part of your talk. Any further questions?
So, do you actually modulate your surgery if the tumor location is nearer to neck? You said invariably you're doing segment 4B5.
Modulate in terms of
liver
on the
resection.
peritoneal side or on the liver side?
The liver resection, if the tumor is situated in the neck of the gallbladder.
Neck of the gallbladder. No, we don't change it. Unless sometimes the neck of the gallbladder tumor will frequently go into the pedicle of the right side, and they may require a modified extended right hepatectomy. And if that is there in the preoperative imaging, then we'll try to consider for tissue diagnosis and neoadjuvant therapy.
And you also said that you don't remove the CBD. What happens in your papillary tumors? Do you do it as a routine or you don't do it?
No, we don't. It is not very frequently found, first of all, and secondly, the recommendation is not for resection of bile duct. For the recent, whatever paper I am reading, it is not recommended.
We had a lot of recurrences in papillary with even in fact a couple of patients in the pancreas as well. So I think they probably might, I don't think there's enough data, but I thought one of the recommendations for bile duct resection was papillary tumors, because you can get just like the urothelial cancers, we can get papillary tumors in the rest of the bile duct as well. So I think probably would be wiser.
Well, if there are no further questions, thank you, Supriyo, for
Thank you.
a nice
Thank
talk.
you.